Bismillahirrahmanirrahim. So now we're going to start with the notes on myasthenia gravis. So the diagnosis of the myasthenia gravis is made with the anticholinergic, anti-acetylcholine or anti-MuSK muscle-specific kinase antibodies. Okay, positive endophonium or tensilon test. Weakness improves, then worsen as tensilon wears off. So tensilon is endophonium. So when we administer the endophonium to a person, the weakness will improve because acetylcholine esterase will increase the amount of acetylcholine in the synaptic vesicles. So the endophonium improves the. But as we previously have seen that the endophonium is effective only for some 15 minutes or so. So the effect tapers off very soon. Then EMG, poor response to the electrical stimulation, that is electromyography will show a poor response to the electrical stimulation. Okay, because electrical stimulation will increase the amount of acetylcholine, I guess, in the in the neuromuscular junction. But if there is no receptor for the acetylcholine to act on, so there will be minute response to the electrical stimulation, which will be evident on the flat line of the electromyography maybe. Clinically, with Simpson test, difficulty sustaining upward gaze, Cogan lid twitch sign, lid overshoots on rapid up gaze. Okay, ice pack test, ice on the eye for 3 to 4 minutes improves the ptosis. Sleep test, that is ptosis improved after sleeping. Fatiguing of the voice during interview and decreased strength with the repeated testing. It is treated with acetylcholine esterase, that is pyridostigmine and neostigmine. Plasmapheresis can be done. Immunosuppressive, for example prednisone, cyclosporine, azathioprine, to reduce the need for the steroids. IV immunoglobulins, monoclonal antibody, for example rituximab and eculizumab. Thymectomy if thymoma is present. Avoid the beta blockers and aminoglycosides. We have to avoid these two drugs, and we have to do the thymectomy if the thymoma is present. Exacerbation of the myasthenia gravis may occur for two reasons. First one is myasthenic crisis, and second one is cholinergic crisis. So we have to differentiate these two conditions as well. In myasthenic crisis, if the patient is undertreated, receives suboptimal doses of medication, not enough acetylcholine is available for the competition with autoantibodies in the neuromuscular junction. Infusion of short-acting cholinesterase inhibitors, for example androphonium or tensilon test, increases the neuromuscular transmission and provides temporary improvement in the symptoms. Cholinergic crisis. In this situation, a patient receives inappropriately high doses of cholinesterase inhibitors and has excessive acetylcholine in the synaptic cleft. The increased acetylcholine causes excessive stimulation of the skeletal muscles and results in the muscles which are refractory to future impulses. The cholinergic crisis also present with muscle weakness. The cholinergic crisis is also going to present with a muscle weakness. Just give me a second, let me set my mic. I hope it sounds better now. So cholinergic crisis also present with a muscle weakness. Then since the neuromuscular junction becomes insensitive to the acetylcholine, and infusion of androphonium produces no improvement. Okay, the neuromuscular junction becomes insensitive to the acetylcholine, so an infusion of androphonium is not going to produce any improvement, or it may also worsen the symptoms. Moving forward to the Raynaud phenomenon. So this is Raynaud phenomenon. The blowing of the fingers is called as Raynaud phenomenon. Blood flow of the skin decreases due to arteriolar small vessel vasospasm in response to the cold or stress. Color change from white ischemia to blue hypoxia to red hyperfusion. So this is ischemia. Then we have hypoxia that gives the blue color and then we have hyperfusion which gives the red color. So all these three color changes are seen in the Raynaud phenomenon, most often seen in the fingers and toes. So these are the fingers which are depicted in this picture over here. Called Raynaud disease when primary idiopathic, Raynaud syndrome when secondary to a disease process such as mixed connective tissue disease, systemic lupus erythematosus or CREST syndrome, limited form of the systemic sclerosis. Digital ulceration, critical ischemia seen in secondary Raynaud syndrome, and you should treat it with the calcium channel blockers. So here you can see the phases of Raynaud phenomena. First phase is phase 1 ischemia. In that the capillaries are like okay, all right, there's no problem with that. Blood flow to the capillaries is impeded, resulting in the digital ischemia. Why is that impeded? Because there is vasospasm of the artery, result in vascular occlusion. So blood flow was supposed to go in that direction, but if the artery is undergoing some sort of vasospasm, so the blood flow is not reaching the capillaries. That is why there is ischemia, and the fingertips will look white, abnormally white. If the vasospasm persists for a longer time, so capillaries and the venules dilate in response to ischemia and are filled with the deoxygenated blood. So the blood that was present, okay, so it looks something like that the blood that was present in the veins, that starts coming back. So if the blood that was present in the downstream veins, if that starts pooling, so that will fill the capillaries as well, and that is deoxygenated blood. So the skin will appear dusky blue due to this vasospasm. And if the vasospasm is relieved, say we gave the calcium channel blockers or stuff like that, so greatly increased flow, relaxation of the vasospasm, and capillaries are still dilated but are low, now carrying the oxygenated blood, so that the dilation of the capillaries, which is persistent, will give the red color to the skin. Okay, moving to the next point, that is scleroderma. So there are two variants of scleroderma. One is diffuse and one is limited variant, that is called crest syndrome. We'll discuss both of them. So scleroderma or systemic sclerosis, it is a triad of autoimmunity, 75% females, triad of autoimmunity number one, then number two is non-inflammatory vasculopathy, and collagen deposition and fibrosis. Collagen deposition and fibrosis is third point. So there are three things together. First one is autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. Sclerosis of skin, puffy and taut skin without wrinkles and fingertip pitting. So puffy and taut skin is over here. That's A. So there is a puffy skin. I guess the puffiness is seen in the periorbital area, maybe over here. So there is puffy skin. Then what do we have? We have taut skin and without wrinkles and fingertip pitting. So there are no wrinkles on the face and fingertip pitting will be seen. I guess over here, maybe the pitting of the fingertips. It can involve other symptoms, for example, renal, pulmonary, GIT, and cardiovascular. So renal, scleroderma, renal crisis, treat with acetylcholinesterase inhibitors. Pulmonary, interstitial fibrosis and pulmonary hypertension. GI is associated with the esophageal dysmotility and reflux. And cardiovascular, two major types, diffuse scleroderma and the limited scleroderma. In diffuse scleroderma, widespread skin involvement, rapid progression, and early visceral involvement will be seen. It is associated with the anti-scleroderma 70 antibody, anti-SCL 70 antibody, anti-DNA topoisomerase 1 antibody. So whole body is involved as a unit. So that is why it's a topoisomerase 1. That's just a mnemonic. Then limited scleroderma, limited skin involvement confined to fingers and face, also with crest syndrome. Okay. So calcinosis, cutis, that is subcutaneous calcium deposition, anti-centromere antibodies. So in the crest syndrome, we find anti-centromere antibodies. So the C of the crest can either be representing the calcinosis cutis, which is this one, the calcium deposition under the skin, or maybe anti-centromere antibodies. Then R is representing the Raynaud phenomena, which we saw over here. This was Raynaud phenomena. Coming back, Raynaud phenomena. Then E is for the esophageal dysmotility. Due to the fibrosis of the distal esophagus, it manifests with symptoms of gastroesophageal reflux, that is heartburn and regurgitation. Sclerodactyly, thickening of the skin of the hand and feet. It begins as non-pitting edema of the hands and fingers. Later, in the course of the disease, the skin becomes thickened, tight, and shiny. Thinning of the skin, atrophy follows. And then we can also find telangiectasia. So this is the mnemonic crest, CREST. Okay. Moving forward to the pathological contractures. So firstly, we'll talk about congenital torticollis. Torticollis is the torsion of the neck because of excessive contraction of sternocleidomastoid muscle on either side. And we'll see the picture now. So it can be dystonic. So no, it is dystonic. Sternocleidomastoid dystonic. Okay, so dystonic means that there is hypercontraction of the sternocleidomastoid, produces head tilt towards the ipsilateral side. Head tilt means the head is tilting to this direction, but the chin is pointing to the opposite direction. Uncertain etiology, possible birth trauma or intrauterine malposition. Infant 0 to 3 months may present with this. It presents as tender, movable mass in the neck. Patients may confuse with neck swelling. Child holds the head tilted to one side. So the head is tilted to the ipsilateral side, but the chin is tucked on the opposite side. Diagnosis with ultrasonography. Treat with physiotherapy, stretching, botulinum toxin or surgery if refractory. May permanently limit the range of movement if untreated. So this is congenital torticollis. Head is tilted towards the affected muscle and the chin points away from the contracted muscle, and this is the contracted sternocleidomastoid, which can be felt as a neck mass. And to diagnose, we have to do the ultrasonography. This is the picture of a child, a real child. Then we'll talk about Volkmann's ischemic contractures. It is muscle necrosis causing irreversible muscle contraction in the forearm, wrist, and hands. Compresses the brachial artery and median nerve. Okay, so firstly we'll talk about the muscle necrosis that causes irreversible muscle contractures in either forearm, in the wrist, or in hands. So it can cause the compression of the brachial artery and the median nerve. May be caused by supracondylar humeral fractures. Supracondylar humeral fractures normally affect the median nerves and brachial artery. Yeah. Then present with a contracture posturing, elbow flexion, forearm pronation, wrist flexion, thumb adduction, metacarpophalangeal extension plus interphalangeal flexion like claw hand. So here you can see The metacarpopharyngeal, so metacarpopharyngeal joint is extended upwards while the interphalangeal joint is flexed. So see that in the picture. So there can be metacarpopharyngeal extension and interphalangeal flexion. Hand is permanently closed. Forcefully extended finger is painful. It can either be permanently closed or it can conform this claw hand formation, and forcefully extending finger is painful. So this is contracture posturing that can be seen. Then we'll talk about clubbing, pathophysiology of clubbing. So here we have the mnemonic for that. We'll see that later. It is not completely elucidated. It is not completely understood. In diseases associated with the right to left shunts, cyanotic congenital heart disease, failure of platelet precursor to fragment completely into platelets within the pulmonary circulation. Okay, so the fragmentation of the platelet precursors into platelets occur basically in the pulmonary circulation, and that process is not completed. That leads to increased megakaryocyte and platelet clumps in the peripheral circulation. Impacted in the fingers and toes, release platelet derived growth factor and vascular endothelial growth factor, promoters of vascularity. They will increase the fibrovascular proliferation, leading to clubbing of the fingers and toes. Elevated level of prostaglandin E2, which activates the platelets via erythropoietin 3 receptors. EP3, okay, I guess it is, I don't know if it is erythropoietin or not, but elevated level of prostaglandin E2, which activate the platelets via EP3 receptors, have also been implicated in the pathogenesis of digital clubbing. This one is far better than this one, but EP3, remember the EP3 receptors and the prostaglandin E2. So I'm sorry for that. Causes of clubbing are listed by the mnemonic clubbing. So cyanotic heart disease and cystic fibrosis, lung cancer, lung abscess, ulcerative colitis, bronchiectasis, benign mesothelioma, infective endocarditis, idiopathic pulmonary fibrosis, neurogenic tumors, and gastrointestinal diseases. Most of the cyanotic conditions, along with ulcerative colitis, and you may think of other conditions like cystic fibrosis, but that is also causing cyanosis. Ulcerative colitis is an odd one, and then benign mesothelioma, infective endocarditis. I guess this is also an odd thing in this picture. Neurogenic tumors, and gastrointestinal disease. So these are kind of non-cyanotic conditions, and others are cyanotic conditions. They have missed the they have missed the liver disease. In CLD, in chronic liver disease, we also find the clubbing in a patient. So remember all of these conditions along with some other conditions which we'll discuss in the respective sections. So this is the normal finger, and then this is the clubbed finger. Moving forward, now we are going to dermatology. In dermatology, skin has 3 layers. First one is epidermis, that is derived from the ectoderm, then dermis, that is coming from the mesoderm, and subcutaneous fat, that is coming from hypodermis or subcutaneous. It is also called hypodermis or subcutaneous. I don't know from which layer is it coming, but the epidermis is from the ectoderm and dermis is from the mesoderm, and then we have hypodermis or subcutaneous, that is subcutaneous fat. Epidermis layers from the surface to the base. Stratum, so it is like CLGSB. What's the mnemonic for that? Is there a mnemonic? CLGSB. So okay, let's see. But the most outer layer is the stratum corneum, that is made up of keratin. This is stratum corneum, and this is keratinized and dead cell layer, mostly characterized by keratin in the anucleate cells. Okay, then we'll talk about stratum lucidum. So this layer just below the stratum corneum is stratum lucidum. So stratum lucidum most prominent in the palms and soles. Then we'll talk about stratum granulosum, G. So stratum granulosum due to the presence of granules within the keratinocytes. Stratum spinosum, which contain desmosomes. So desmosomes give the shape of the spines from the cells, hence it names what spines. Okay, so due to the desmosomes, the cells become spiny maybe, and that is why they are called as desmosomes. Then stratum basale, the stem cell site over there, stratum basale. So responsible for the regeneration of the new epidermis attached to the basement membrane by hemidesmosomes. So desmosomes are present in the layer stratum spinosum, while hemidesmosomes are present in the stratum basale. They are very important because when we study about pemphigus vulgaris and another pemphigoid something, so in that these two things are very important. So remember that the stratum spinosum is characterized by the presence of desmosomes, and stratum basale is characterized by the presence of hemidesmosomes. Here you can see keratinocytes and melanocytes. So what's the mnemonic? Like they have highlighted that, and I guess there's no mnemonic over here. There would be a mnemonic in the first aid 2022. Let me bring that. So it is first aid 2022, and here we have a mnemonic along with a better picture. So here you can see that the mnemonic is come let's get sunburned. So it's like C, stratum corneum, that is come, then stratum lucidum, it is let's, G is for the granulosum, S is for the spinosum, and B is for the basale. So come let's get sunburned. Good mnemonic. And then here you can see the most outer keratinized or anuclear layer is stratum corneum. Then just below stratum corneum we have stratum lucidum. Below that we have stratum granulosum, stratum spinosum, which contains spiny cells. If you can see in this picture, they are the cells with the spines, and they contain desmosomes. And then we have stratum, no, not granulosum, the stratum spinosum. The stratum spinosum contains desmosomes, and stratum basale, the lower layer, the blue layer, that is containing the hemidesmosomes. Hemidesmosomes, if you would like to say that, like, okay, hemidesmosomes, and then we have dermis below that. So epidermis, all the layers which we are studying, like with the mnemonic and all that, corneum and lucidum, corneum, lucidum, granulosum, spinosum, and basale, all of these layers are coming from the ectoderm, while the dermis is coming from mesoderm. Okay, let's come to the picture. So these are the layers as in the real histology side. So let's come to the main picture. So in this picture we have seen these layers, and then this is the picture I was referring to. So there is also, okay, that's not a very modest mnemonic, but there's a mnemonic called Californian like girls in string bikinis. Okay, good for Californians. And here we have the layer that come, let's get sunburned. That's a good one. So you may also remember it like that. Then we have skin thick trichome. What's that mean? I guess it's some stain. So stratum corneum, then we have stratum granulosum and stratum lucidum, then stratum spinosum, stratum basale, and then dermis. Okay, so now it's very important because I used to confuse it. I supposedly, like when I was solving the Uworld questions, so I used to think that this is epidermis above this, and now we have dermis below that. It's wrong. All of the purple layer, the whole of this layer, these are different layers of the epidermis, and the whitish layer below that, that is dermis. So this is epidermis, whole of that, and here we have the dermis below that. The whole layer, the whole thickness from here all the way up here is epidermis, and the dermis is below that over here. So remember these things. Now we'll talk about dermatologic microscopic terms. So we'll talk about some terms. Firstly, we'll talk about hyperkeratosis. Hyperkeratosis means increased thickness of stratum corneum. So the stratum corneum, which is the most outer layer, stratum corneum over here, or maybe you may say over here, stratum corneum, if the thickness of the stratum corneum increases, that is called as hyperkeratosis, because that is the keratinized layer, right? So hyperkeratosis means increased thickness of the stratum corneum. Example is psoriasis and calluses. Parakeratosis, retention of nuclei in the stratum corneum, that is seen also with the psoriasis. So we know that this layer is anucleate, but if there is some retention of the nuclei in this layer, that is called as parakeratosis, and parakeratosis is also seen with the psoriasis. Hypergranulosis, increased thickness of stratum granulosum. Hypergranulosis is called increased. Hypergranulosis means increased thickness of stratum granulosum, and that is seen with the lichen planus. The stratum granulosum is below the stratum lucidum over here, and stratum granulosum is called granulosum because of the presence of granules within the keratinocytes. And if there is excessive production of stratum granulosum, that is called hypergranulosis, and that is seen with the lichen planus. Okay, then spongiosis, epidermal accumulation of edematous fluid in the intracellular spaces. Spongiosis means the skin becomes spongy. That is in the intracellular space. You may say these are the cells. In between the cells, we have the accumulation of fluid, and that will, the edematous fluid basically, and that will make the skin looking like a sponge. So that thing is called as spongiosis. Okay. After spongiosis, epidermal accumulation of the edematous fluid in the intracellular spaces, that is called, for example, in the eczematous dermatitis. Then acantholysis, separation of the epidermal cells. So acantholysis means the epidermal cells are separated from the dermis below. So the separation, it can be within the layers of epidermis, or maybe the separation is between the epidermis and dermis. In both the situations, it is called as acantholysis, and this condition is seen with the pemphigus vulgaris. Acanthosis, epidermal hyperplasia, increased spinosum. So acanthosis is epidermal hyperplasia, that is the spinosum layer. What spinosum? This layer, the stratum spinosum. If this is hypertrophied or this is increased in quantity, so that condition is called as acanthosis. Epidermal hyperplasia increased in the spinosum layer, and that is seen with the acanthosis nigricans, the black pigments which are appearing in the armpits or stuff like that. So hyperkeratosis means increased thickness of the stratum corneum, psoriasis. Parakeratosis, retention of the nuclei in the stratum corneum, seen in the psoriasis again. Hypergranulosis, increased thickness of stratum granulosum, seen with the lichen planus. Spongiosis is edema, fluid. Eczematous dermatitis. Acantholysis means separation of the epidermal cells, pemphigus vulgaris, and acanthosis is the condition with epidermal hyperplasia is there. Epidermal hyperplasia increased spinosum and acanthosis nigricans. Okay, then we'll talk about epithelial cell junctions. They're very, very high yield because they ask you, and a lot of pathologies are associated with them. So we'll talk about them one by one. Firstly, let's talk about tight junctions. So tight junctions are the, suppose this is cell number 1 and this is cell number 2. So the tight connections between the cell is going to form the tight junctions. They are formed by the zona occludens. These are the proteins. No, this is the name of the tight junctions. Okay, so tight junctions are also called as zona occludens. Prevent the paracellular movement of solutes composed of claudins and occludins. So these are the proteins. The claudins and occludins are forming the tight junctions, and the function of tight junctions, which are also called as zona occludens, they prevent the paracellular movement of solutes. Paracellular means from cell to cell like this. So they are preventing that. Then we have adherens junction, that is called as belt desmosomes or zonula adherens. What do? They are below the tight junctions, forms belt connecting actin cytoskeleton of the adjacent cells with cadherins. Okay, so the adherent junctions, they are going to connect the actin cytoskeleton by the cadherins, calcium dependent adhesion protein, that is why they are called cadherin. Loss of E cadherin promotes metastasis, because we have discussed that so many times now. Let's suppose there is a cell and there is another neighboring cell. Both of these cells are connected together by cadherin proteins. If the E cadherin junction is broken down between the cells, so resultantly these cells are free to move, and if they are metastatic cells, so they are free to metastasize in the case of a malignant tumor. So they are called as adherens junctions. Tight junction is basically a glue which is sticking the two cells together and does not allow any kind of paracellular transport. The adherens junction is connecting the actin of the two cells together by cadherin, that is calcium dependent adhesion proteins. Then what is the thing about desmosomes? So here you can see that tight junctions they have occludins. The adherent junctions are formed are formed of E cadherins. Then desmosomes. So desmosomes are formed by cytokeratin, sport desmosomes, macula adherens. Okay, so the desmosomes are also called as sport desmosomes or macula adherens. Structural support by intermediate filament interactions. Autoantibodies to desmoglein, pemphigus vulgaris. So if there are autoantibodies directed against the desmogleins or desmosomes, which are present in which layer? Stratum spinosum. So if the desmosomes have antibodies directed against them, so the person develops pemphigus vulgaris. So just give me a second. Let's correlate this. We saw that in acanthosis, in pemphigus vulgaris we have acantholysis. Acantholysis means separation of the epidermal cells. So epidermal cells get separated. Why are they getting separated? Because the desmosomes which were connecting the cells together, like these ones, we have antibodies directed against them, and if we have antibodies directed against them, resultantly what do we get? Pemphigus vulgaris, right? Then we'll talk about gap junctions. Okay, so there is desmoplakin. I don't know what that is. Cytokeratin and desmoplakin, I guess these are two proteins which are forming the desmosomes. Then talking about gap junctions, channel proteins called as connexins permit the electrical and chemical communication between the cells, that is connection with the central channel. Okay, then we have cell membrane, and below that we have basement membrane. Okay, got it. So here you can see a visual picturization. I guess it is an electron microscopic picture of what maybe it's a gap junction, I guess. Oh no, for me it is looking like a tight junction, but I don't know. And here is some other sort of junction over here. Here is a junction and here is a junction maybe. So stick to this picture and the explanation. Then we have hemidesmosomes. So what is the function of hemidesmosomes? They connect the keratin in the basal cells to the underlying basement membrane. Autoantibodies will cause bullous pemphigoid. Hemidesmosomes are down below. So they are basically, hemidesmosomes are connecting the cells to the basement membrane. What cells? The cells of the stratum basale. So the stratum basale that contains hemidesmosomes, and hemidesmosomes are going to connect the cells with the basement membrane, because this is the layer that is adherent to the basement membrane. The stratum basale is adherent to the basement membrane, so we have hemidesmosomes for them. The stratum spinosum is not present on the basement membrane. They are present above the stratum basale. So we have desmosomes which are connecting each other. So if the problem is with the desmosomes, we'll have pemphigus vulgaris, and there will be separation between the layer, that is called as acantholysis. And if we have antibodies directed against hemidesmosomes, so we'll have bullous pemphigoid, and stratum basale will be affected. So coming back, now here you can see that hemidesmosomes connect the keratin in the basal cell to the underlying basement membrane. Autoantibodies will cause bullous pemphigoid, and hemidesmosomes are down below. And integrins, what do they do? integrin membrane protein that maintain the integrity of the basolateral membrane by binding to the collagen, laminin, and fibronectin in the basement membrane. So basically, hemidesmosomes and integrins are doing pretty much the same thing. Okay, so integrins are maintaining the integrity by binding to the extracellular matrix proteins, and hemidesmosomes are binding directly to the basement membrane. Okay, so hemidesmosome bind to the keratin, while the integrins are binding to the laminin and fibronectin and collagen, but basically basement membrane. So both of them are binding to the basement membrane proteins. Skin glands and adnexal components, sweat glands. Duct open into skin surface, myoepithelial cell facilitate the expulsion. So the sweat glands have their duct opening on the skin surface, and the myoepithelial cell which is surrounding the ducts, surrounding the parenchyma of the duct or maybe the duct tubules, they will facilitate the expulsion onto the surface. Type of exocrine glands. So we're done with sweat glands with this explanation, and now we'll talk about general type of exocrine glands. Firstly, they can be merocrine, apocrine, or holocrine. Merocrine means cell will secrete via exocytosis. They include salivary glands, eccrine sweat glands, and apocrine sweat glands. Apocrine, okay, so there's an explanation to that. We'll see this after this table. So merocrine means the cell is secreting via exocytosis. Suppose this is a cell, and whatever secretion is going to secrete will secrete via exocytosis in the form of a vesicle or maybe freely into the extracellular environment. Then apocrine, cell secretes via membrane bound vesicles. So no. This is just going to do the exocytosis, not vesicle, just free substances into the environment. Apocrine glands are the ones which secrete via membrane bound vesicles. For example, the mammary glands. And the holocrine, cell lysis release the entire contents of the cytoplasm and cell membranes. For example, sebaceous glands and meibomian glands. That is why they're so, these secretions are very bad smelling, or they smell very bad because the cell has died and there is some necrotic process going on. That's just my analogy. They're not supposed, maybe there is some secretion that is not very smelly or something like that, but holocrine glands, the whole cell is involved and the cell dies out in the process of making the secretion, and this is seen with the sebaceous gland and the meibomian glands. So let's see the difference between eccrine and the apocrine sweat glands. So the eccrine and apocrine sweat glands. Eccrine. The eccrine, a type of simple sweat gland that is found almost all the region of the skin. The gland produces sweat that reaches the surface of the skin by the way of coiled tubule. The body is coolest as sweat evaporates from the skin versus apocrine. So eccrine sweat glands cover over most of the body and open directly onto the skin surface. Apocrine glands open into the hair follicles leading to the surface. Okay, so basically the eccrine glands exit directly, while the, okay, so you can see it here. These are the eccrine glands which are opening directly onto the skin, while the apocrine glands, they are associated with the these things, the hair follicles. So they are entering or opening into the hair follicle, and then they will emit on the surface. So remember this thing. Now let's move forward to the next picture. Sebaceous gland. So sebaceous gland associated with the hair follicles. Okay, sebaceous glands are also associated with the hair follicles. Widespread except the palm, soles, and lower lip. They are not found over there, I guess. They produce the sebum, bacteriostatic and emollient, via holocrine cell death near the ducts, and stimulate the androgen. Emollient is like, a very layman term, but I don't know the meaning of that, so we'll see it over here. Emollient. The emollient means that having quality of softening or soothing the skin. Okay, moisturizer. Yeah, moisturizer, good word. Then coming back to the dermatologic macroscopic terms. We have seen the microscopic terms, and now we'll see these macule, patch, flag, blah 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 blah. They are very confusing, but now we'll see the difference between them. The skin lesions, if they are flat, so we'll see the size. If they're less than 1 centimeter, they are macule. If they're bigger than 1 centimeter, they are a patch. So flat means that there is just a color change, you may say that. There is just something on the skin which cannot be palpated, just a color change of pigmentation can be seen on the skin, and you cannot palpate that thing that is over the skin, you may say that, or under the skin. That is a good word. So if it is flat lesion, smaller than 1 centimeter will be a macule, and larger than 1 centimeter will be a patch. Talking about the elevated skin lesions, if they are smaller than 1 centimeter, it is a papule. If it is bigger than 1 centimeter, it is a plaque. And if it is fluid filled, less than 1 centimeter is a vesicle, more than 1 centimeter is a bulla, and if contains pus, it is a pustule. So they have not discussed the petechiae and purpura over there. I guess they will discuss it later on, maybe or may not be. Okay, so let's come back. So we have to be clear among these things. Petechiae and purpura, the difference between petechiae and purpura is that the petechiae are pinhead lesions, small lesions, pinhead lesions, and the purpura is the larger one, and ecchymosis is even larger. So it goes like petechiae is smaller than purpura, which is smaller than petechiae is smaller than purpura, and that is smaller than ecchymosis. So that is we saw that in the hematology section. So petechiae then purpura then ecchymosis, these are the side differences, and now forget about that. Now we'll talk about the lesions which are normally found in the skin, the macroscopic lesions. The first one is flat. If it is less than 1 centimeter, we'll say it macule. If it is more than 1 centimeter, it is patch. Skin lesion less than 1 centimeter will be a papule. Okay. Remember, like papilloma virus is something, it is not associated with the papule, but the papilloma virus is a very, very small virus. So a smaller elevated lesion will be a papule, and the larger one will be a plaque. That's a very, weird kind of mnemonic. So I know you can make good mnemonics, so make a very good mnemonic for that and tell me in the comment section. The fluid filled mnemonics, if it is less than 1 centimeter, it is a vesicle. If it is more than 1 centimeter, it will be a bulla, and if it contains pus, it is pustule. So here is the difference again. So macules, flat lesions with well circumscribed change in the skin color less than 1 centimeter. Examples are freckle and labial macule. Freckle and labial macule, you can see it over here in this picture. There is a flat lesion on the lips, so that is a macule. Okay, then patch is a macule but greater than 1 centimeter. So if a macule becomes bigger than 1 centimeter, that is called as a patch. Large birthmark and congenital nevus, they are called as patches. So you can see it over here. A larger macule more than 1 centimeter, since some people have birthmarks or maybe a very big mole or something, so that is called as a patch. Got it? Then we have papule. So papule is elevated. So now we're done with the flat lesions. One is macule, the smaller one, and the larger one is called as a plaque. Okay, what is papule? The papule is elevated solid skin lesion less than 1 centimeter. The mole or nevus and acne, they are examples of papule. Acne will be classified as pustule maybe, but let's talk about papule. So here is the picture of a mole. So this thing, that is an elevated lesion on the tip of the nose that is less than 1 centimeter. That is why it is called as a plaque. Not plaque. Yeah, that's papule. I'm sorry. If it is less than 1 centimeter, it is called as a papule. It will be termed plaque if it is more than 1 centimeter. And that is seen as a psoriasis. So a plaque is something that is bigger than 1 centimeter. Here you can see the plaque. So whenever we talk about psoriasis, we say like very frequently or in flow that these are the plaques with scaling or silvery scales over them. So the plaque means an elevated lesion which is more than 1 centimeter in diameter, while if it is less than 1 centimeter, so that is called as a papule. So we are done with the macule, the the patch, then we did the papule, and now we are done with the plaque. And talking about moving further, now we are going to talk about vesicles. So we are done with the elevated lesion. Now we'll talk about the fluid filled lesions. Okay, done with this one over here. Now talking about the fluid filled lesions, the vesicle is small fluid containing blister less than 1 centimeter. For example, chicken pox and shingles, they produce vesicles because the papules and plaques, they are not fluid filled. If the elevated lesion is fluid filled and less than 1 centimeter in size, that is called as vesicles. So now here you can see a lot of vesicles. Okay, so these are a lot of vesicles which are less than 1 centimeter in size each, and they are seen with the chicken pox, varicella zoster virus, or shingles and stuff like that. Then bulla is large fluid filled blister more than 1 centimeter, and that is seen with the bullous pemphigoid. And bullous pemphigoid is a disease of the stratum basale, and the stratum basale, the problem is basically the formation of autoantibodies against the hemidesmosome. So that is a bullous pemphigoid, and here you can see a large fluid filled bulla which is more than 1 centimeter definitely in size, and that is fluid filled as well. Then we'll talk about pustule. So pustule is a vesicle containing pus, and that is seen in the pustular psoriasis. Pustular psoriasis is some other condition which we have not studied yet. We'll see that later. But pustule is a pus filled lesion, the vesicle that is containing pus. So it is basically a vesicle that is containing pus. So here you can see, if you can see it, it is pustular psoriasis. So it is a pustular psoriasis. Here you can see the accumulation of pus in these areas. So this is the pustular psoriasis. Now we'll talk about wheal. Okay, so we are done with these lesions. Let's revise them quickly. macule and patch, flat lesion, less than 1 centimeter macule, more than 1 centimeter patch. Elevated non-fluid filled lesions, smaller than 1 centimeter papule, larger than 1 centimeter plaque. Fluid filled lesions, smaller than 1 centimeter vesicle, larger than 1 centimeter bulla, and if it is filled with a pus, it is called as pustule. Now let's talk about wheal. So wheal is transient smooth papule or plaque. Transient smooth papule or plaque. Papule over here or plaque. So if it is transient and smooth, that is called as wheal. Okay. Hives in the urticaria. So here you can see that these are the heaves or hives which are found in the urticaria. They are transient in nature. They can either be papules, that is less than 1 centimeter, or plaques, that is more than 1 centimeter. Both elevated lesions. In the case of allergy, they can form, and they are transient in nature. They will go as soon as the allergic reaction is weaned out or something. Then scale, flaking off of stratum corneum. Stratum corneum is the most outer layer. If it is flaking off, that is called as scale or scaling. So eczema, psoriasis, and squamous cell carcinoma. Eczema, psoriasis, and squamous cell carcinoma. Here you can see that the outer layer of this thing, whatever it is scaling off, or it is being removed. Then coming back to the picture, the crust, they are dry exudates and they are seen with the impetigo. So there you can see the cheeks of the child is having dry exudate of the impetigo over here. So that is the crust. So it is like all of these words, that's a spoiler, but all these words they mean pretty much the same thing when we use them in English. But when we are going to use use them specifically in the dermatology, and specific macroscopic terms have been devised to refer to different things. So that is why you have to remember these things. Make good mnemonics, use dirty medicine or some other YouTube video which have mnemonics for that, but remember this thing because this is something that they ask you most often on the step exam from the dermatology section. You need to differentiate between these things. So wheal is transient plaque or papule, the scale is flaking off of the stratum corneum, and the crust is dry exudate which is seen in the impetigo. Now let's move forward to this Uworld point. They are saying that red blood cell extravasation into the skin or subcutaneous tissue result in the formation of petechiae which are less than 5 millimeters, purpura 5 millimeter to 1 centimeter in diameter, or ecchymosis that is more than 1 centimeter in diameter. Okay, petechiae are the smallest, then the purpura is the intermediate lesion, and then ecchymosis is the largest lesion. These lesions do not completely blanch under pressure, unlike telangiectasia. So telangiectasias will blanch. Telangiectasia is a lesion like this over there, and they're also called as spider nevi. So if you will compress with a needle or with your finger on the center over here, that is the site of origin of all these branches, so that telangiectasia will fade off. But the ecchymosis and purpura usually do not blanch very well. What is lentigo? Lentigo is a small tan or brown macule. It is basically a macule seen on sun exposed skin, for example face, hand and arm. It is lentigo. Lentigo. Yep. So lentigo is a small sharply circumscribed pigment macule surrounded by the normal appearing skin. Here you can see the lentigo. This thing is called as lentigo, or this is the picture of lentigo. Lentigo. Now this is also very similar to the cafe au lait spots. Let me show you. Cafe au lait spots. So they look similarly. Okay, cafe au lait spots. So these are cafe au lait spots. Now you can see that those lesions and these ones are very similar to each other, right? But you have to read the question stem properly for the proper history. Then you have to see the picture if that helps you, and if that does not help you, it is not a big problem. Go with the other available information, like they may be giving you an information about tuberous sclerosis, I guess in this case, or maybe pherofibromatosis type 1. So something will be there to make the diagnosis very clear, but also keep these terms in your mind, like these ones. These are very, very high yield and very important. Remember these lesions, and then remember the lentigo as well. Telangiectasias, small focal permanent dilation of the superficial capillaries and venules found in the skin or mucous membranes, blanch under pressure because the red blood cells present as confined to the vasculature. They blanch under the pressure because the telangiectasias will blanch under pressure because the red blood cells present as confined into the vasculature. Why will they blanch? Because the red blood cells have not leaked into the skin. They're still present in the blood vessel. So if you will compress the blood vessel, the lesion will be blanching. But if the red blood cell is extravasated under the skin, for example in the case of ecchymosis or purpura or petechiae, so you cannot blanch that lesion because red blood cells have already come out. So here you can see a telangiectasia. Telangiectasia. So telangiectasia is depicted over here. telangiectasia blanching. Okay, yeah, here you can see that's a good picture. So in the on the left side you can see a telangiectasia over here. This is a telangiectasia, and when you compress this with anything, there in this picture they're compressing it with the glass slide. So when you compress it, so the lesion is gone in this picture. Okay, so let's come back. Where are we? Yep. So remember the lentigo and telangiectasias. Lentigo is a brown macule seen on sun-exposed skin, face, hands, and arms. Then talking about pigmented skin disorders, basic principle: melanocytes. They are present in the basal layer of the epidermis, the stratum basale. Okay. So here you can see the stratum basale, and in the stratum basale we have melanocytes like this. So these are the brown one. This brown cell, that is a melanocyte, and they are present in the basal layer of the stratum basale of the epidermis. Got it? Then derived from the neural crest cell. Melanocytes are derived from the neural crest cell. They synthesize the melanin in the melanosomes using the tyrosine as a precursor molecule. Okay, the people who have phenylketonuria or tyrosine, some enzyme deficiency, like I don't remember that, phenylketonuria, phenyl hydroxylase deficiency, which they cannot produce the tyrosine, and if tyrosine is not being produced, so downstream melanin production is also reduced. So resultantly these people have albinism, but we'll see that after this topic. So synthesize melanin in the melanosome using the tyrosine as a precursor molecule, pass melanosomes to keratinocytes, skin pigmentation. So melanosomes are produced over here. They are produced, melanosomes, the melanin pigment is produced here. Then melanosomes are passed all the way up to the stratum corneum and the upper layers, which will express the pigment, and the skin tone will be maintained. So here you can see that the melanosomes are passed to the keratinocytes and the skin pigmentation will be seen. What is albinism? Congenital lack of pigmentation is termed as albinism. Normal melanocyte number with decreased melanin production due to decreased tyrosinase activity or defective tyrosine transport. What is it? Normal melanocyte number. Melanocytes are normal in number with decreased melanin production, but just melanin is not being produced. Otherwise, the melanocyte number is normal. Due to the decreased tyrosinase activity, tyrosinase enzyme is all the way over here, I guess here. So DOPA to be converted into melanin, we need the enzyme tyrosinase. If tyrosinase is not functioning properly, so the person will develop albinism, diffuse hyperpigmentation, and increased risk of skin cancer. Then we have an NBME point. Melanocytes are neural crest cell derivatives, and failure of the neural crest cell migration can contribute to albinism, but these forms are much more rare. That is, if the question gives you both options, go with the decreased tyrosinase activity and melanin production. So most of the time they don't confuse you with these questions, like they're not going to give you the similar options, but since it is step 1 and they can do anything, so if they're giving you similar options like either the neural crest cell deficiency or the tyrosinase deficiency, so you must go with the tyrosinase deficiency because that is more common than among these two conditions. Okay, so now this is tyrosine catabolism pathway. The first one is phenylalanine, which is a non-essential protein, I guess, but I don't know. Phenylalanine is an amino acid that is broken down into tyrosine via phenylalanine hydroxylase. This enzyme is deficient in phenylketonuria, and there is another type of phenylketonuria in this dihydrobioterin synthase. Now dihydrobioterin reductase deficiency can also cause phenylketonuria, but we'll see that later on. Then we have tyrosine. Tyrosine is converted into DOPA by again dihydrobioterin. DOPA is converted into dopamine, and dopamine by the DOPA decarboxylase, and melanin by tyrosinase enzyme, and the vitamin B6 or pyridoxine is being used for the reaction as a cofactor. So remember this thing from here to here because it is very highly asked upon concept. Moving forward to the vitiligo. So vitiligo is irregular patches of complete depigmentation. There is a myth that if you drink milk immediately after eating the fish, so you can develop vitiligo. So it is this thing. So that's totally a myth. It is a crap. Don't remember that. So irregular patches of complete depigmentation. It is caused by autoimmune destruction of the melanocytes. In contrast with the albinism, that have melanocytes that do not produce the melanin because of the absence of defective tyrosinase. So remember that in the case of albinism, the melanocytes are normal. They are just not producing melanin. Right? They are sitting there comfortably. They are not doing their function. But in the case of vitiligo, it is an autoimmune destruction of the melanocyte in which the melanocytes are gone in particular areas of the skin. For example, here you can see the hands don't have melanocytes, and maybe what's that? I guess it is leg or something else, maybe trunk, I don't know. But there is patches of depigmented skin. Component of severe autoimmune disorders. It can be a component of several autoimmune disorders. For example, the polyglandular autoimmune syndrome type 2, PGAS, PGAS. That's also called PGAS, I guess. PGAS. You may find it written something like that. PGAS. So polyglandular autoimmune syndrome type 2, autoimmune thyroid disease, for example, Hashimoto thyroiditis and Graves disease. Hashimoto thyroiditis is a condition in which we find hypothyroidism, and in the Graves disease we find hyperthyroidism. Both of them are autoimmune disorders. Then pernicious anemia and Addison's disease, type 1 diabetes mellitus and inflammatory bowel. IBS. IBS is not in. IBS is irritable bowel syndrome. IBS, if I'm not wrong. Yep. Okay. Then we'll talk about melasma or chloasma. Melasmas, hyperpigmentation associated with pregnancy. Okay. Melasmas, xanthelasmas, maybe there is also condition. Okay, let's come back. So what is melasma? Melasma is also called as chloasma. Okay. Hyperpigmentation associated with pregnancy. She must be a pregnant woman and now she is having hyperpigmentation on the face, mask of pregnancy. Okay, so that is a transient condition, maybe because that is called as mask of pregnancy, or oral contraceptive. So it is associated with a pregnancy or oral contraceptive and the face looks something like this. Okay, that is melasma. It is exacerbated by the sun exposure. Treatment: topical hydroquinone, bleaching cream, sunscreen and sun avoidance. Cessation of contraceptives usually fades over months following pregnancy or cessation of contraceptives. So it is a transient condition if you will stop being pregnant or you will stop taking the OCPs. So this condition will wean off, and that the mask of pregnancy will be gone, but it will take months. So you can give the topical hydroquinone for that, or you may give the sun avoidance along with sunscreen, so that may help. Hydroquinone is basically the bleaching cream. Moving forward to the freckles. They are most common pigmented lesion of the childhood, especially in the light-skinned individuals. So in the Caucasians, you can find freckled skin like this. So the most common pigmented lesion of the childhood, cause it is autosomal dominant condition, and due to the increased number of melanosomes, melanocytes are not increased. Now again, it's a very important concept. Remember, the melanocyte number until the conditions which we have discussed till now, they are decreased only in vitiligo. There is destruction of the melanosomes in this condition that we call vitiligo. That is the only condition where there is destruction of the melanosomes, melanocytes. Okay, this is melanocyte and they have melanosomes. Okay, so melanocytes are destroyed as a whole in the case of vitiligo. In the case of albinism, melanocytes are intact but the melanosomes are gone. And in the case of freckles or ephelis, okay, freckles. So in the case of freckles, the melanocytes are all right, but there is increased production of the melanosomes. So melanosome production is enhanced. Due to the increased number of melanosomes, melanocytes are not increased. Presentation: small 1 millimeter benign pigmented tan red or light brown macules. So these are tan red or light brown macules. Remember what macules are? Macules are flat lesions which are less than 1 centimeter in size. So now we are talking about 1 millimeter, like they're even smaller than a centimeter. So these are called as macules. So these freckles are basically macules. Fade and darken in cyclic fashion with sun exposure, changing seasons. So the children may get hyperpigmentation during summers and hypopigmentation of these freckles in the winters. Limited to the face, arms and upper trunk. Cafe au lait spots are histologically similar. Cafe au lait spots are histologically similar to all the macules, but they are more similar to these lesions, but are independent, but they arise independently of the sunlight, contain macromelanosomes, aggregated melanosomes. Treat with sunscreen and sun avoidance. So how to differentiate between the freckles and cafe au lait spots? The cafe au lait spots will be developing in the areas where there is no sun exposure at all, like on the abdomen or maybe on the buttocks or maybe on the legs, somewhere where the sun exposure is not very common. But the freckles are very confined to the areas where we have sun exposure, for example on the face or the arms, and that is also moving with a cyclical fashion. In the case of on the histology of the cafe au lait spot, what do we find? We find aggregated melanosomes. Then we'll talk about lentigo. We just have seen that. Lentigo is a 5 to 10 millimeters oval tan brown macule or a patch. If it is small, it will be called macule. If it is large, it's called patch, but mostly it's a macule, resulting from benign melanocyte hyperplasia. Now there is melanocyte hyperplasia, like the melanocytes will increase in number. The melanocytes are going to increase in number, and that increase in melanocyte count will cause lentigo. Do not darken with sunlight. Histology: linear non-nested melanocytic hyperplasia producing hyperpigmented basal cell layer. So basal cell layer become hyperpigmented because of increased in melanocyte count. Again, in albinism, the problem is decreased production of melanosomes. Melanocyte count is normal. In the case of vitiligo, melanocytes are destroyed as a whole. In the case of melasma, that is the face mask of pregnancy. Then in the case of freckles, the melanosomes are increased in number, melanocytes are just normal. In the case of lentigo, the melanocyte count is increased and there is melanocytic hyperplasia. Remember these things, and then we'll continue from the pityriasis versicolor, a fungal condition, from the next session. Until then, Allah Hafiz, take care and fi amanillah.